the doctors and the public about promoting mental health. So I welcome my co-MOC Nausheen Sheikh to speak a few words about mental health. Dr. Nausheen.
Thank you, Jagruti ma'am. Good afternoon, ladies and gentlemen. I'm myself, Dr. Nausheen. I feel privileged to welcome you all for this mental health webinar as an effort or attempt to acknowledge the World Mental Health Day. As per WHO, health is defined as physical, mental, and social well-being and not merely an absence of disease. Thus, mental health is an important parameter to define a person healthy. There is a saying, it is easier to say my tooth is aching, but difficult to describe my heart is broken. Thus, mental pain is less dramatic than the physical pain, but it is more common and more hard to bear. With this, I would ask Dr. Jagruti ma'am to call upon Dr. Sakib Danish and give his brief introduction. Over to you, ma'am.
Said Dr. Nausheen, and we welcome Dr. Sakib Danish, sir, the brain behind the CME. Sir's humbleness is known to all of us, and his super orations we have witnessed in multiple CMEs. Yeah, the next one. Okay, so sir is a consultant psychiatrist practicing in Mira Road since last 17 years. He is the owner of Mind Care Clinics, president of Healthy Mind Foundation, and past president of MRMAFT, trustee and EC member of Thane Psychiatric Society. Welcome, sir.
Good afternoon, everyone. Am I audible? आवाज आ रही मेरी?
Yes, sir.
Yes, sir.
Okay. Thank you, sir. Thank you. मैं बहुत बहुत शुक्रिया अदा करता हूँ मनोज और उसकी टीम और सारे एसोसिएशन का जो एक बार में सब रेडी हो गए कि मेंटल हेल्थ सीएमई करना है हम. So big hand to all the associations of Mira Bhander, including dental, including orthopedic, including gynec और सारे 8 एसोसिएशन को big hand. और मैं दिल से इस्तेमाल करता हूँ इस मेंटल हेल्थ सीएमई में ताकि सब लोग सुन सके, अपने आप को मेंटली और स्ट्रॉन्ग बना सके. Before starting, I would like to start with a poem. It's time to speak of illness, not just wellness. It's time to shatter the stigma and to ponder over the enigma. It's time to speak of illness that are labeled mental in a manner so gentle. It's the stress that leads to all the mess. Psychiatric illness are an interplay of molecules in the brain that keeps you sane. Investigations of which are difficult to obtain. It's about sadness and not just madness. It's about worry, difficult to bury. It's about fear, made clear. It's about obsession, not in your possession. It's your emotion that leads to all the commotion. It's your behavior which is no more your savior. It's your thought that needs to be fought. It's up to discuss. It's up to us to discuss that concealment is impeachment, but treatment is achievement. Mental health is our real wealth, and to speak about it at length is my real strength. So, my dear friends, I welcome you all for this mental health CME, and we have a good 20 Psychiatrist Association of Healthy Mind Foundation of Western Sabah from Borivali to Dahanu, and I welcome Doctor Psychiatrists who have joined us for this CME, and I welcome all of them and all the physicians who have come, all the other faculties who have come to join this CME, and I tell Dr. Nausheen to invite the speaker. Rashmi Singh.
Thank. With this, I would like to call upon our first speaker, Dr. Mansi Jain, who is going to put some light on child psychiatry, emotional issues in children, and how to identify and manage them. Dr. Mansi Jain, she is private practitioner in Borivali. She is co-founder of Man Arogya Psychiatric Clinic. She has done DNB Psychiatry, fellowship in child psychiatry, postgraduate diploma in medical legal systems, and she is trained in rational emotive behavior therapy, and play therapy. Dr. Mansi Jain, over to you, ma'am.
May I please request for screen sharing?
Yes, ma'am. Give me a second. Ma'am, you are now host. You can share.
Thank you. So today we are going to talk about emotional and behavioral issues in children. So why have I chosen this topic? So the answer is that, no definition of health is complete without mental health. And the prevalence of psychiatric issues or mental health issues is very high in school going children. 50% of people who developed any mental health issue in adulthood have actually started, the issues have started in their childhood. And when you are actually a child and your mental health gets affected, you do not achieve your true potential, be it academically, be it socially. And it's always easier to build strong children than to fix broken adults. So is this something new? Many people think that child psychiatry की नया फैड है, पहले नहीं होता था. ये अभी अभी लोगों में बात हो रही है कि बच्चों को थोड़ी कोई साइकाट्री का तकलीफ हो सकता है, बट ऐसा नहीं है. Children in the past also used to struggle with mental health issues और अभी भी रहता है. Only thing is that earlier we were not aware, we were not diagnosing them. They would just drop out of school, stop attending school, or enter the family business या किसी जॉब पे लग जाते थे. Now that there is more awareness, there is more information about this, we know that there are children who struggle with mental health issues, and that's why we are having this webinar. One more thing that is there is that modern society has led to a modern life, and because of this, there are certain problems which are very much new, like we will see in today's world, which were not there earlier. But even if these new problems were not there, there were other issues which children always struggled with. The first emotional problem that I want to talk about is temper tantrum. ये बहुत ही common है. Mostly parents for temper tantrums के लिए psychiatrist के पास नहीं आते, but हम हमेशा families में देखते हैं, या जब बच्चे हमारे क्लिनिक में आते हैं या पेरेंट्स आते हैं हमारे पास, तब हम देखते हैं कि ये बच्चों का बिहेवियर बहुत कॉमन रहता है. तो भी टेम्पर टैंट्रम, व्हाट इज इट? टेम्पर टैंट्रम इज बेसिकली एन इमोशनल मेल्टडाउन या एन इमोशनल आउटबर्स्ट व्हेन डिमांड्स आर नॉट मेट. सो एक यूजुअली कॉमनली जब सुपरमार्केट में या मार्केट में हम बच्चों को लेके जाते हैं, दैट टाइम वी सी दिस, द चाइल्ड वांट्स अ टॉय, द चाइल्ड वांट्स अ चॉकलेट, एंड इफ द पेरेंट्स रिफ्यूज, द चाइल्ड विल स्टार्ट क्राइंग, ही विल सिट ऑन द फ्लोर, वहां से हिलेंगे नहीं. सो दीज आर बेसिकली अ स्ट्रॉन्ग इमोशनल स्टॉर्म विच द चाइल्ड इज हैविंग. अब ये क्यों होता है? इज बिकॉज द चाइल्ड्स ब्रेन इज डेवलपिंग. द चाइल्ड हैज नॉट yet developed ability to control his or her emotions. जैसे कि अगर हमको कोई ना बोल दे किसी चीज के लिए तो शायद हमें भी बुरा लगता है, but we have the ability to control our emotions and hence we will not throw a temper tantrum. हम रोने नहीं लग जाते हैं उस चीज को लेके, but children brain is not yet completely developed and hence they develop a temper tantrum when they hear no, especially when they want something. Also children are understanding that they have एन ऑटोनॉमी, यानी वो खुद की डिमांड्स रख सकते हैं या वो पेरेंट्स से अलग है. हर चीज जो पेरेंट्स बोलते हैं वो नहीं करनी है और इसीलिए टेम्पर टैंट्रम हो जाता है. What happens is that बहुत many times the child is hungry or frustrated or tired and उसकी वजह से भी temper tantrum हो जाता है. So that is why we say that अगर आपको पता है that आप लंबे समय के लिए मार्केट जा रहे हैं, your child is going to get hungry there, so make sure you are carrying food with you, या आप हमेशा पहले बच्चे को नैप करा ले फिर उसके बाद लेके जाए तो ताकि बच्चा टायर्ड ना रहे. So how do you manage temper tantrums? The commonest mistake जो पेरेंट्स करते हैं या ग्रैंड पेरेंट्स करते हैं ज्यादातर हमारी फैमिलीज में, कि बच्चे की डिमांड्स जो है वो फुलफिल कर देते हैं. तो अगर बच्चा रो रहा है, चॉकलेट चाहिए, तो हम तुरंत चॉकलेट दिला देंगे उसको चुप करने के लिए. हम सहन नहीं कर पाते कि बच्चा रो रहा है या बच्चा रोते हुए हम सुने. इससे क्या होता है कि द चाइल्ड लर्न्स दैट every time I cry, my parents will give me what I want. या if parents are not giving, then दादा दादी बोलते हैं क्यों रुला रहे हो, दे दो बच्चे को, एक चॉकलेट ही तो मांग रहा है. So this is the biggest mistake we do when temper tantrums are there in kids, that we give into their demands, या हम उनकी demands fulfill कर देते हैं. So understand that doing that is not going to help. हम एक बार अगर देंगे, the child is definitely going to ask for it the second time. Many times the best thing to do is ignore when the child is throwing a temper tantrum. So if the child is crying, if the child is just, हाथ पैर पटक रहे हैं, इग्नोर कीजिए. जब तक अगर बच्चा अपने आप को हार्म नहीं कर रहा है, या कभी कभी कुछ बच्चे टेम्पर टैंट्रम में बहुत सीवियर एंगर दिखाते हैं, where they bang their head on the floor. Unless ऐसा कोई रिस्क है, अगर वैसा रिस्क नहीं है तो इग्नोर करना बेस्ट चीज होती है. जहां पे आपको पता है कि टेम्पर टैंट्रम के चांसेस ज्यादा है, जैसे कि मार्केट में, शॉप में, वहां पे बच्चों को आप हमेशा प्रिपेयर करके लेके जाइए. उनको पहले से खिला के लेके जाइए, पहले से सुला के लेके जाइए, या उनको बोल के लेके जाइए कि हम वहां पे कुछ नहीं खरीदने वाले हैं आपके लिए, या सिर्फ एक ही चीज खरीदनी है तो आप चूज कर सकते हो, बट उसके अलावा और कुछ नहीं. काफी बार डिस्ट्रैक्ट करने से भी बच्चों का टेम्पर टैंट्रम कम हो जाता है. और जब भी बच्चा गुड बिहेवियर करता है तो हमें उसे प्रेज करना है या रिवॉर्ड देना है. एक चीज हमें समझनी है कि पेरेंट्स बहुत एम्बेरस हो जाते हैं कि बच्चा सड़क पे रो रहा है, मार्केट में चिल्ला रहा है, तो पेरेंट्स को बुरा लगने लगता है, शर्म आने लगती है कि कहीं हम बैड पेरेंट्स तो नहीं है. बट ऐसा नहीं है. टेम्पर टैंट्रम्स आर अ पार्ट ऑफ नॉर्मल डेवलपमेंट. ऑल किड्स थ्रो टेम्पर टैंट्रम्स टू सम एक्सटेंट, एंड पेरेंट्स डोंट हैव टू फील बैड अबाउट देम, बिकॉज जो लोग आपको देख रहे हैं शायद उनके घर पे भी बच्चे हैं और वो भी टेम्पर टैंट्रम्स थ्रो करते हैं. सो इट्स नॉट अबाउट यू एज बैड पेरेंट्स. So don't get angry, don't get embarrassed, don't give in to the child's demand when you are managing a temper tantrum. Second thing which we are seeing very commonly after COVID is school refusal, because of children have becoming used to online school, because of children who were never exposed to school, जिन्होंने नर्सरी या केजी, जूनियर केजी, सीनियर केजी ऑनलाइन करी है और अभी फर्स्ट सेकंड स्टैंडर्ड उनको स्कूल जाना पड़ रहा है. वी आर सीइंग अ लॉट ऑफ स्कूल रिफ्यूजल. स्कूल रिफ्यूजल में क्या होता है कि द किड रिफ्यूजेस टू गो टू स्कूल, कि मुझे स्कूल जाना ही नहीं है, तो सुबह उठते ही सर दर्द, पेट दर्द या रोना शुरू कर देंगे. या अगर स्कूल पहुंच भी जाएंगे तो स्कूल पहुंचने के बाद सर दर्द, पेट दर्द की कंप्लेन करेंगे, और फिर पेरेंट्स को उनको स्कूल से छुड़वा के घर पे लेके आना पड़ता है. Generally, we say that school refusal is not a symptom, it's a sign कि कुछ तो और गड़बड़ है. यानी कि it's not a disorder in itself, but जब बच्चे को anxiety हो रही है, या अगर बच्चे को bullying की जा रही है स्कूल में, और the child is being abused somewhere, it is very likely that the child will present with school refusal. Many times, certain anxiety disorders like attachment disorders which children develop can also present with school refusal. Another thing that happens is that if there is domestic violence at home, घर पे अगर पापा मम्मी के झगड़े होते हैं और बच्चा वो देख रहा है, तो बहुत टाइम बच्चे को ये डर होता है कि if I go to school and if I'm at school and when I come back, maybe my parents will not be at home, or maybe my parents will leave me and go because they is seeing so much of fighting. So because of this problems, there is school refusal. So whenever we see school refusal और बच्चा स्कूल जाने को मना कर रहा है, so we always try to find out कि इसमें से क्या चीज हो सकती है. ऑफ लेट हम देख रहे हैं कि बहुत बच्चों को गेमिंग एडिक्शन हो गया है और उसकी वजह से स्कूल रिफ्यूजल है. सो बच्चे घर पे रहते हैं, पूरा दिन मोबाइल खेलते हैं और स्कूल जाने के लिए बिल्कुल मना करते हैं. सो उनके ये थोड़े से बड़े बच्चे होते हैं, छोटे बच्चे नहीं है ज्यादा. या कुछ बच्चों में एकेडमिक डिफिकल्टीज है, जैसे वो लोग 5th 6th स्टैंडर्ड तक अच्छे से स्कूल जा रहे थे, बट जैसे ही एकेडमिक लोड बढ़ गया 7th स्टैंडर्ड के बाद, उन्होंने स्कूल जाना मना कर दिया या बंद कर दिया. तो ये सब चीजें हैं जिनको हमको अंडरलाइंग प्रॉब्लम्स को ट्रीट करना पड़ता है. अंडरलाइंग प्रॉब्लम्स को ट्रीट करना पड़ता है, उसी के बाद स्कूल रिफ्यूजल करता है. अभी स्कूल रिफ्यूजल जब है, जब बच्चा कि आप मत जाओ, अगर आपको स्कूल जाने से एंजाइटी होती है तो आप मत जाइए. हमको पहली चीज जो कर उसका कॉज फाइंड आउट करने के बाद उसको हमेशा हमेशा स्कूल में री इंटीग्रेट करना है. यानी द इवेंचुअल गोल इज दैट द child has to go back to school. We need from the school counselors and teachers as well. So we usually what we do is graded exposure. So first, agar we have found out the cause, then we treat bullying in school. We make sure that there is no bullying. We give be like cognitive behavior therapy or play therapy to help with their mood issues. And when it is about going to school, something graded exposure, यानी आज हम स्कूल के गेट तक जाएं, बच्चे को थोड़ी एंजाइटी होगी, थोड़ा सा अनकंफर्टेबल लगेगा, बच्चा कंफर्टेबल हो जाएगा. फिर नेक्स्ट डे वी विल गो टिल द staircase of the. Then third day we will go till the classroom, but we will not sit in the classroom. We will come back. Then Monday we will period and come back. So gradually the child learns that school is not such a bad place or a scary place, and school can be okay, and I can. Many here also that parents say कि अगर नहीं जा रहा है school तो they let them home, and schools are also saying कि ठीक है आप सीधा exam के लिए लेके आओ, especially if the child is young. Remember that should never be done. We always have to send the child back to, because school is not important just for studies but for social development of the child as well. If the child is struggling with severe anxiety or severe issues, then sometimes we have to use medicines also to help the child. So anxiety medicines given. Third emotional problem that we see commonly in children is bedwetting. Now, bedwetting again is developed. Most their bed and it is completely open. Most of the children are dry. So, if after 7 years you are still experiencing bedwetting in a child, type in primary bedwetting has never controlled. You control करना सीखा ही नहीं और वो हमेशा कर रहा है. And in secondary, the child has been 1 year but bedwetting. Usually, secondary bedwetting when it starts, it is because of some emotional problem. So the child was doing okay, now is being bullied in school or now is experiencing abuse in school, and because of that, it's bedwetting. We also have organic problems like urinary tract infection, constipation, because when there is constipation, children don't have control, proper sphincter control, so they control both the stools and the urine, and then when they pass urine also along with that. If it is that is there is no other problem that the child is having emotional problem, it usually resolves by its own. But if the urination is frequent, the child's hygiene is being compromised, if there are other problems that are happening, we give parents certain techniques by which the bedwetting. So the use is that you have to train the child to go to the bathroom. So toilet independently bathroom use करना, ये हमें करना पड़ता है बच्चे को. Second thing with parents is that after don't give them too many, give only soup for dinner, or if you are giving milk, then don't give a big milk in the evening, give more milk. So when there are liquids in your body in the evening, the amount of urine which night is less, and therefore less chance of bedwetting. Another thing we tell them is that before bed, always form a routine that the child goes to the bathroom and then goes on the bed. If you know that the child is, bed or passing or 4, उसके half an hour पहले अलार्म लगा उठाना है और बच्चे को बोलना है बाथरूम में के यूरिन करके वापस आओ. If it is not be, sometimes we see kids of 10 years, 12 years also coming to us with bedwetting problem. Then we sometimes have to use medications like imipramine, which help in the bladder. However, it is not a very long-term solution, and we have to make sure that the child learns to do proper toilet training. If it is not treated, it does have a lot of consequences, because a lot of guilt and shame is also when the child understands that he is bedwetting, this condition also. The next thing that I want to talk about is attention deficit activity disorder. This is a very, very common disorder in children, but it is very less diagnosed, because हमको लगता है कि ये बच्चा सिर्फ naughty है, but it's not that the child is naughty, is actually struggling with some problem. So attention deficit disorder has domains. It has inattention, hyperactivity, and impulsivity. So inattention की वजह से the child trouble or difficulties focusing at one thing, difficulty remembering things, difficulty completing tasks. तो अगर आप बच्चे को बोलोगे कि जाके ये सामान वहां पे रख के आ जाओ, बच्चा जाएगा बीच में ही दूसरा काम करने लग जाएगा. Or if the child is making a school project, the child will not finish the school project, just leave the project and start going and playing or start doing some other homework. So this is how inattention is affecting the child. These children also lose things very commonly. So parents will say कि उसको हर रोज हमको होता है. Every year we have, because he loses water bottles, umbrella. So these are the common symptoms of inattention, ADHD. It means having a lot of energy. Children place that thing the child will turn behind friends, or I'm telling them to sit down. And parents they tell us that इसको बाहर लेके जाता है तो हमको इसका हाथ पकड़ के रखना पड़ता है, नहीं तो ये भाग जाता है, नहीं लगता है पकड़ना है. या अगर हम रिलेटिव्स के यहाँ लेके जाते हैं तो बोथ ऑफ अस हम दोनों जन इसके एक एक बाजू बैठते हैं ताकि ये कूदा कूदी करके कुछ तो. So the common problem that activity presents with. And impulsivity means that these children have poor impulse control, means that they want some patient बहुत जल्दी बोर हो जाते हैं. कहीं पे भी अगर लाइन है तो उनको कहीं पे भी टाइम लगने वाला है तो वो बहुत ज्यादा रोने लग जाते हैं. So what happens is that all प्रॉब्लम्स उनके एकेडमिक्स पे अफेक्ट होता है और उनके सोशल रिलेशनशिप्स में भी अफेक्ट होता है. एकेडमिक्स बिकॉज द चाइल्ड इज नॉट एबल टू पे अटेंशन school. And what happens in social relations is that because these children are very hyperactive, they don't play properly. Like while playing also they will break rules or they will become impulsive and not follow rules. So people don't want to play with them. Other children don't want to play with them. Relationships also. ADHD is not treated in children. When they become develop low self-esteem, they develop of anxiety, because all their life when they were growing up, people have only shouted at them, told them you are very not bad. So what happens is that many times they also drop from school. If ADHD is severe, child will not be able to study properly. And if the child is not able to study properly, if he has no interest in studies, he will leave school. If they leave school, they fall into bad company. They do all kinds of wrong things, like starting to do small crimes like stealing or trying drugs. So that is why we say that ADHD is something which needs to be treated. Otherwise, it has a lot of long-term consequences. Many times बच्चों को लर्निंग डिसऑर्डर या लर्निंग डिसेबिलिटी जो हम कहते हैं डिसलेक्सिया, उसके साथ में भी ADHD पाया जाता है. Now, what happens is that when you talk about treatment of ADHD, the first thing and the most important thing is that we have to psychoeducate the parents, explain to them that why this is a neurodevelopmental condition and it is based on your brain development, and how treating this is going to help your child. When the child is very small, we can start with occupational therapy. Now, occupational therapy is something which focuses on fine motor development, gross motor development, balance issues, coordination issues, and sitting tolerance of the child. Most of the times, we also need support of medications to treat ADHD. The medications that are used for treating ADHD are called as stimulant medicines, and they increase the dopamine levels in your brain, and that is why they are available only with certain prescriptions. So parents get usually very scared that अरे हमारे बच्चे को ऐसी कौन सी दवा दे रहे हैं जो मिलती नहीं है, या it's so bad. But it's a very safe medicine to be given in children, and it is used all over the world for children who struggle with ADHD, and the results are remarkable when we use this medication. In this condition as well, we need support from the school, we need support from the teachers. We tell them that अगर आपको लगता है ये बच्चे को ADHD है तो आप इसको फर्स्ट बेंच पे बिठाइए ताकि आपकी नाक के नीचे रहेगा तो मस्ती कम करेगा या डिस्ट्रैक्ट कम होगा, या ask the child, give the child some responsibility so that the child feels good. Otherwise, what happens is that in ADHD, the child is always only getting criticism that he is a naughty child or he is very irresponsible. But when the teacher is giving responsibility to the child feels very good. And that is why it is very important to treat ADHD with the help of teachers, school counselors, and parents. Next thing that I want to talk about is something we called as defiant behavior. Now, defiant behavior is nothing but doing the opposite of what I have been told. मतलब कुछ बच्चे जो हम बोलते हैं ना कि rebel without a cause. Everything that the parents will request, the child will do the opposite of that. Even if the child wants to do it, the child just because parents ने बोला है अब तो मैं उल्टा ही करूंगा. ये बच्चे बहुत ज्यादा आर्ग्यूमेंटेटिव होते हैं या बैक आंसर करते हैं. ये पेरेंट्स का बहुत कॉमन प्रॉब्लम होता है. जो उनकी कंप्लेंट्स होती है, दे आर वेरी हर्टफुल एंड वेंचफुल, यानी बदले की भावना रखते हैं. तो अगर मम्मी ने आज डांटा है ना, तो कल मैं मम्मी का काम कैसे बिगाड़ूंगा ना, ये जानबूझ के उनको इतना ध्यान में रहता है. So that is a problem with these kids. They are usually doing the opposite of what they are requested to do, and they get in a lot of problem with school authorities. या जैसे उनके जो घर में बड़े हैं या स्कूल में बड़े हैं टीचर्स, उनके साथ हमेशा उनका प्रॉब्लम चलते रहता है. So whatever the teacher says, they don't want to listen. Whatever the parents say, they don't want to listen. Now, this is an emotional problem that develops because the child is missing something. So we say that, children who need the most love ask for it in the most unloving way. So जिन बच्चों को सबसे ज्यादा प्यार की जरूरत है, सबसे ज्यादा सपोर्ट की जरूरत है ना, उनका बिहेवियर इतना बुरा होता है कि हमको लगता है कि इन बच्चों को हम प्यार कर ही नहीं पाते. So similarly, when these children are back answering, when they are fighting, when they're doing the opposite or arguing, it means that there is something going on with them. Like, हो सकता है they have ADHD, because of which they are not studying in school, because they have learning disability, they are getting poor marks, their friends are teasing them, or there are parents who are very harsh with them, and that is why they are kind of, having this kind of behavior. When we talk about treatment of defiant behavior, we have to understand that the parents need to be involved in this big time, because the defiant behavior is at home and at school mostly. We need to make sure that the parents understand how to react when the child is behaving badly. बहुत पेरेंट्स को लगता है कि इसको अगर मारेंगे, इसको अगर हम स्ट्रिक्टली बिहेव करेंगे तो ठीक हो जाएगा, बट नहीं होता है. जो डिफाइंट बिहेवियर होता है वो बढ़ जाता है, और हम देखेंगे कि हाउ दिस डेवलप्स इनटू समथिंग वी कॉल एज कंडक्ट डिसऑर्डर. सो अगर हम बच्चा डिफाइंट है, बच्चा जो हम कह रहे हैं उसकी रिक्वेस्ट हमारी नहीं मान रहा है, सो वी हैव टू अंडरस्टैंड दैट देयर इज सम emotional problem going on with the child. We need to solve that, number one. And number two, the parents need to change the way they react to the child or they interact with the child. Sometimes we have to use medications to treat the aggression if the child is very aggressive. But remember कि सिर्फ punishment देने से ठीक नहीं होता है. अगर हम डिफाइंड बिहेवियर को ठीक नहीं करते हैं ना, सो व्हाट डेवलप्स इज समथिंग वी कॉल्ड एज कंडक्ट डिसऑर्डर. कंडक्ट डिसऑर्डर इज नथिंग बट जो बच्चे हम कहते हैं कि तड़ी पार हो गए हैं, या जो हम जुवेनाइल जस्टिस एक्ट में फंस जाते हैं, या जो जुवेनाइल रिमांड होम्स में मिलते हैं. सो दे हैव जस्ट गॉन बियॉन्ड आर्ग्यूइंग विद पेरेंट्स और फाइटिंग विद टीचर्स, एंड दे हैव ब्रोकन द लॉ, दे हैव ब्रोकन रूल्स, दे हैव हर्ट अदर पीपल, और दे हैव डिस्ट्रॉयड प्रॉपर्टी. तो झूठ बोलना, चोरी करना, चीजों को आग लगा देना, चीजें तोड़ देना, चक्कू यूज करना, अपने पास वेपन्स रखना, ये सारी चीजें जब बच्चे करने लगते हैं तो हम कहते हैं कि कंडक्ट डिसऑर्डर में डेवलप हो गया है. एंड यूजुअली ये बच्चों को अगर हेल्प नहीं मिलती है, और मोस्ट ऑफ द टाइम्स व्हाट हैपेंस इज दैट दे ईदर गेट स्टक इन द लीगल सिस्टम, तो वो लोग रिमांड होम में या चाइल्ड वेलफेयर कमिटी के उसमें फंस जाते हैं, or else then they develop into something we called as antisocial personality. So the antisocial elements like the people in society who would probably be doing a lot of crimes and breaking a lot of rules. Now these children are actually very good children, but they have not gotten a good environment, and that is why these problems have developed. So they are usually coming from broken families, or where parents themselves are into such activities, or there's a lot of domestic violence, or they have experienced a lot of adverse childhood events in their childhood, and that is why they have developed something like this. The important thing that I want to say about this is that जब भी हम लोग ऐसे बच्चों को देखते हैं तो हमको लगता है कि इनका कुछ नहीं हो सकता है, इनको तो बस रिमांड होम में ही रखना चाहिए, और they can never improve. बट ऐसा नहीं है. With long term intense therapy they can also get better, and they can also lead a good life. Last and the most important thing that we see nowadays is gadget addiction. So it's not just cell phone addiction, laptop, computers, iPads, everything is being used too much by kids. इसे एक हम बिहेवियरल एडिक्शन कहते हैं. जैसे गैम्बलिंग हो गया, जैसे कुछ बिहेवियर्स है जो हम रोक नहीं पाते, कंपल्सिव ईटिंग है. सो इट इज अ फॉर्म ऑफ एडिक्शन, दो इट इज नॉट अ डायग्नोजेबल डिसऑर्डर, बट इसके लक्षण जो है, साइंस एंड सिम्टम्स बिल्कुल एडिक्शन से मैच होते हैं. बहुत सारी स्टडीज की गई है जहाँ पे देखा गया है कि ब्रेन में जो चेंजेस होते हैं वो भी वेरी मच सिमिलर टू एडिक्शन है. सो जो केमिकल चेंजेस है या न्यूरोलॉजिकल चेंजेस है इन गैजेट एडिक्शन, दे आर वेरी मच सिमिलर टू अदर एडिक्शंस. एंड गैजेट्स आर डिजाइन टू बी एडिक्टिव. जैसे हम जो स्क्रोल करते हैं दैट इज एंडलेस ना, कभी भी खत्म ही नहीं होता है. सो दैट इज वाई, और व्हेन वी पुल डाउन टू रिफ्रेश, ऑल ऑफ दीज बिहेवियर्स आर वेरी addictive. So if the phone is not available, these children will become anxious, they will become aggressive, they will break things if phone or gadgets are not given to them. So what we need to do is that acknowledge there is a problem. Many times parents like say कि नहीं नहीं ये तो सिर्फ phone ही use कर रहा है, it's not a big problem, and that is why they don't do anything about it. But we need to understand that this is a problem. इससे बच्चे की mental health affect होती है, number one. Number two, academic health plus the social health, all three of them get affected. You need to start early for this. Don't wait कि addiction develop हो जाता है फिर हम उसका treatment करेंगे. जब बच्चे छोटे हैं, जब हम सेल फोन को या iPad को access दे रहे हैं, तभी ही हम देखें कि हम कुछ बाउंड्रीज सेट करेंगे कि हम कितना टाइम के लिए दे रहे हैं. अगर हम गैजेट ले लेते हैं और बच्चा टेम्पर टैंट्रम थ्रो करता है, बिकॉज ये कॉमन है कि फोन ले लिया तो बच्चा रोता है, सर पटकता है, तो हम टेम्पर टैंट्रम को मैनेज करना सीखे, ना कि हम उसको फोन या गैजेट दे दे. वी नीड टू हैव डेटा लिमिट्स, वी नीड टू टर्न ऑफ नोटिफिकेशंस. ये सारी चीजें हमको हेल्प करती है ताकि फोन से ज्यादा अटैचमेंट या पूरा कंसंट्रेशन उसके ऊपर ना हो. एंड वी नीड टू टेक प्रोफेशनल हेल्प ऑल्सो टू ट्रीट दिस समटाइम्स. लास्ट डिसऑर्डर दैट आई वांट टू टॉक अबाउट इज स्टटरिंग एंड स्टैमरिंग. एंड ये मैंने इसलिए यूज किया है, दैट इसलिए इंक्लूड किया है बिकॉज ये बहुत ही कॉमन होता है बट इसके लिए हेल्प नहीं ली जाती है. सो स्टटरिंग या स्टैमरिंग इज डिसरप्टेड फ्लो ऑफ स्पीच. बेसिकली बच्चे जो अटक अटक के बात करते हैं, या हम लोग हिंदी में जिसको हकलाना कहते हैं. सो इसके लिए व्हाट हैपेंस इज दैट यू नो अ लॉट ऑफ इमोशनल डेवलपमेंट में प्रॉब्लम होता है. सो व्हेन किड्स आर स्टटरिंग दे गेट मेड फन ऑफ. देयर आर किड्स हु डोंट प्ले विद सच चिल्ड्रन और दे always make fun of such children. Even teachers kind of make fun of them, or parents or in the bade log in the house might make fun of them. So these children develop a lot of anxiety and depression when they grow up, and that is why we need to take treatment for this. Usually speech therapy and teaching the child relaxation techniques is something that can help.
Kabhi? Okay, which school?
We also need to use cognitive behavior
हो गया?
therapy and relaxation techniques to help the child deal with stuttering and stammering. And sometimes if the child has developed anxiety or depression because of this, then we might need to use medications to help the child overcome that as well. So that's my presentation. Thank you so much.
Thank you, Mansi ma'am. That was an amazing presentation, and I'm sure that all of us are having this problem at home about gadget addiction in children and gadget addiction among our spouses. So with that, we move to our next speaker, Dr. Rashmi Singh, who is going to enlighten us about psychiatric symptoms in women, trends and patterns. Dr. Rashmi Singh, she is an MBBS from JJ Hospital, MD Psychiatry from KEM.
Hello. Ma'am, make me host again, please make me. Yeah.
Hello, can you hear me?
Hello.
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 Hello. Am I audible?
Yeah, Rashmi, we can hear you.
Ma'am, you are audible.
Yes. Dr. Manoj, can you allow me to share the screen?
Yes, ma'am.
Yeah.
Yeah, you can share now.
Hello, Dr. Manoj, can you hear me?
Yes, ma'am.
Okay.
I have allowed
before
Dr.
just
Rashmi to
introducing
share.
Dr. Rashmi Singh, madam. She is an MBBS from JJ Hospital, MD Psychiatry from KEM Hospital, Fellowship in Child Psychiatry from Nair Hospital, with special interest in women and child mental health. She is attached to Lifeline Medicare Hospital, Goregaon West, and Sai Kripa Hospital, Malad East. Welcome, ma'am.
Thank you. Thank you, Dr. Jagrati, for having me here. And yes, good afternoon, everyone. First of all, I would like to wish everyone a very happy World Mental Health Week. I am here to talk about mental health issues in women. So, to start with, I would give a few facts and stats about women mental health. And so, women accounts for almost 50% of the world's population, as we know, across all age groups. But here are some of the facts and statistics given to us by the World Health Organization. So, when we see 1 in every 8 people in the world live with a mental health disorder, out of which the most common mental health disorder, depression. We have the prevalence of around 41.9% in women as compared to men. The leading mental health problems of elderly are depression, organic brain syndrome, and dementias, majority of whom are women. So an estimated 80% of the 50 million people affected by violent conflicts and civil war, disaster, and displacements are women and children. So the lifetime prevalence rate of violence against women ranges from 16 to 50%. At least 1 in 5 women suffers from rape or attempted rape in their lifetime. So yes, it raises a concern amongst the health professionals. And why do we think that we have such a high prevalence of mental health issues in women? When I ask that question, I think the answer that comes to most of our mind is that the hormones, maybe the physiological changes. So women differ physiologically as compared to men. But is that the only answer that we have, that having a different physiology will make us more prone and vulnerable to the mental health disorders as compared to men? Is physiology is the only answer? The, well, the answer is no, that is not the only answer. If that was so, then about 50% of the world population would have had the mental health, different kinds of mental health disorders today, but that is not the fact. So what is it other than hormones? Talking about hormones, hormonal fluctuation over lifetime can make them, yes, more vulnerable during those periods of puberty, menopause, pregnancy. As we know, puberty is common. It comes for both men and women. So both are vulnerable during that time, out of which pregnancy and menopause, it's specific for women, and it shows its changes only in them, and they may suffer from different mental health disorders during that time. But apart from hormones, there is one more important thing that we need to think about. That is the social and the cultural aspects of the society that mainly affects the women health issues. So today I am here to basically put some light on that social and cultural aspects which separate women from men, and how do they actually put their effect on their mental health. So to start with, let us see India. So India has a patriarchal model of control, and in this patriarchal society, women are disproportionately affected by mental health problems. Their vulnerability, they are closely associated with their work and marital status and their roles in society. So yes, they are judged most of the times, and what we see is that there is a very high expectation from the women of our society. To a certain extent, they are always performing a lot of times. Mother of the house, she's expected to handle the kitchen, if they have young children at home, take care of the young children, they are nursing. And if they are studying children, school going children, they have to take up the studies as well as help the family in the financial crisis and support the family financially. So there are a lot of burdens which is there on a woman. She is being judged by someone or the other most of the times. How do I explain this? Suppose there is a working mom who one day, once in a while, she gets late at office and she comes home late. Yes, there are people at home. I won't say all of them, but there are people at home in our society who judge them that maybe she is selfish. She is all about work, and she um, she's not caring about the family. She doesn't take the responsibility of the family. If the same woman leaves office early one day for some work, or she has something at the family to do or something, she is being judged at the office as well, that she is more about the family and everything. If she has to leave early every day and all of us are working over here, then she can quit the job. Then there is a third scenario wherein if she leaves the job and she becomes a homemaker, then there is another judgment coming along saying that maybe she doesn't want to handle or support the family financially. These girls, they take up the jobs that we want, and they just finally end up doing babysitting. So yes, there is a lot of judgment involved out in the society. Apart from this, what I would like to say is there are predetermined gender roles which are assigned to our women. Apart from gender roles assigned, there are gender behaviors which are assigned to them. It puts a lot of limits on their autonomy, their choice, which leads to mental health concern. There is a pressure to conform their gender role expectations, and those who are non-conforming, they face a lot of censure, they face a lot of judgment from others, which leads a lot of distress, and finally leading to mental health disorders. So as I said, not only they are assigned certain gender roles, but they are assigned certain behaviors as well, and certain symptoms. What will come to your mind when I ask you, if you get a man in your OPD, male coming to your OPD and who is giving complaint of getting overwhelmed since a few days, bursting into tears, shortness of breath, what are they supposed to do? They might have faced, even they face some judgments in their society. अरे भाई, लड़कियों की तरह क्यों रोते हो? आदमी हो, आदमी की तरह रहो. They get to hear a lot of such things. So as health professionals, we know that getting overwhelmed, getting emotional, bursting into tears, being sad, shortness of breath, these are anxiety symptoms. We know that. But in certain society, this is assigned to girls in our society. They get to hear, this is what girls do. You are a woman. They are supposed to be pleasant and soft and good. They have to show a good part of their femininity. So yeah, there are standards with respect to the women personality in India as well. They are supposed to be reserved, shy, and modest. They are supposed to behave in a submissive manner. They have to be, or they are mostly orthodox and traditional. They are actually taught since childhood how much they have to work after marriage and what are the family values they should have. So basically, I just gave you an idea about the social and the cultural factors that mainly affect women in our society. So now I'm going to go and put some light on the common mental disorders that women have. So the most common mental health disorder that women have is depression. Uh, talking about the facts, approximately 280 million people in the world are affected by depression. So when it comes to women, it is twice as common as compared to men worldwide. When we talk about pregnant women, about 10% of them experience depression. Stats say that more than 7 lakh people die due to suicide every year. And when we think about women who constitute half of the population, the number is pretty more. So about the symptoms of depression, how do they present to our OPD? Mainly, the most common denominator is the depressed mood. We have to assess the mood. So what do you ask? A depressed mood doesn't always say that they will be sad and low lagta hai, doctor. Yes, they could be irritable since a very few days, and there might be emptiness inside, which they might not tell you, but you have to ask your patient. They might come to you just for the complaint of डॉक्टर फोकस करने नहीं होता है पढ़ाई में या जॉब में या घर में कामों में मन नहीं लगता है. There is inability to concentrate. There are vegetative symptoms like disturbances in sleep and appetite. They might have lack of sleep, late onset sleep, increased appetite, and low appetite. So there might be a feeling of worthlessness. There might be a feeling that nobody can help them. There might be hopelessness about their future, that there is no hope in the future. Um, Talking about women, yes, some of them might just come to you for headaches and pain and aches and digestive complaints like डॉक्टर बहुत गैस होती है और गैस मेरे सिर में चढ़ जाती है. They might give you certain symptoms which you might think कि क्या हो सकता है. You might run a certain test, everything is normal. You might give treatment, maybe painkillers, antacids, PPIs, but there is hardly any improvement. That is the time when you should explore more, talk more about the symptoms, ask more about the symptoms, what are they are facing at their home, at their job, and outside. Then another symptom that we commonly seen is lack of energy. They just feel tired all the time. So the next after depression, yes, severe, what I would say, severe symptom of depression or clinical feature is suicidal ideations. A patient coming to you with complaint of depression or depressive symptoms, you should always ask about whether or not they are having a suicidal ideation, because that is an emergency. So yes, I would like to next go to the next common mental health disorder, that is anxiety disorder. So anxiety disorder, especially in both the genders, male and female, they may present as both psychological symptoms and there is physiological symptoms. Physiological symptoms as in they might come to you with shortness of breath. They might come to you with tingling sensations in the hands, heaviness in the chest, non-specific chest pains, coldness of the hands and the extremities, and headaches, sometimes blurring of vision. So all these complaints, they might come to you. These are the physiological symptoms of anxiety that we have to understand, because they don't know that it is anxiety. They will just come to you कि छाती में दर्द होता है, छाती में दर्द होता है. You have to explore more. After you do your ECG and sometimes 2D echo, you do, but everything is normal, then you have to explore more. Explore more about the anxiety disorder. They might not tell you that उनको घबराहट होती है. They might not even realize that उन्हें घबराहट होती है, उन्हें anxiety होती है. What are the psychological symptoms of anxiety? So these are frequent worry about that interferes with their daily life. They may be withdrawn from their social life. There is a fear of the next panic attack that they might have experienced in the past. There is irrational fear or avoidance of a harmless object, place, or a situation. They might have out of blue panic attacks. Out of blue panic attacks in the sense they will not give you any stressor. They will not have any thought or something. They are just happy and they are into a function or they are into a market or somewhere, and they just start experiencing the panic attack symptoms. So yes, classical panic attack do come like that. There might be a feeling of impending doom. They might feel that they would not survive the attack. There might be recurring nightmares wherein they get up in the night and with palpitations, sweating, and shortness of breath. All these complaints they might come to you with. Next common disorder which we see is obsessive compulsive disorder. So yes, obsessive compulsive disorder, this basically means it has two components, basically obsession and compulsion. So what obsession means, they are intrusive thoughts, unwanted thoughts, and irrational thoughts that the patient doesn't want. A thought like मेरे हाथ गंदे हैं. They are washing it again and again, but still they keep getting the thought continuously that मेरे हाथ गंदे हैं. A thought like मैंने शायद गैस का नॉब बंद नहीं किया है. They have checked it twice, they have checked it thrice, but still they keep getting these thoughts that गैस का नॉब उन्होंने बंद नहीं किया है. That's pathological doubt. They might get a certain sexual thoughts, obscene sexual thoughts, which might be disturbing them. They might not open up with you. But yes, what we see is there are a lot of compulsive behaviors that they happen. Like, for example, if they are getting these thoughts of haath gande hain, and there is contamination, you might just observe excessive hand washing. They're spending too much time in the bathroom, bathing for like hours, 4 hour, 3 hour, just washing the body part and the bathroom and everything again and again. So most of their time is spent into all these, and this affects and interferes their basic daily routine. They are not able to take care of the family. They are not able to go to the work, not able to sleep. I have got patients who get up like 4 a.m. in the morning because they have to make breakfast for their family, for their children and the husband. So that starts by 6 a.m. But before that, she has to take bath and everything, for which she takes at least 1.5 hours. So she has to go to the bathroom like 4 a.m. in the morning. And for that, she's not able, there is a lack of sleep. So there are other symptoms. They might develop secondary depressive features. They might develop suicidal ideations. So yes, we need to take care, and we need to be very keen and observe what are the basic behaviors. Some of them may get blasphemous thought. So they might get thoughts of abusive languages in their brain, that they are abusing God, or abusing some authority figure. So yes, there is a lot of distress associated with obsessive compulsive disorder. The next disorder is specific for women. It is associated, it's called postpartum depression, and it is seen during the peripartum and the postpartum period. So, what is different? Yes, one answer is again hormonal changes. The peak of estrogen and progesterone that we see during the pregnancy. After pregnancy, there is a sharp dip in the hormones that affects women emotionally. But do every woman suffer from postpartum depression? No, that doesn't happen. So, what are the other factors that actually affects them mentally? So these are the expectations related to the new mother in our society. She must be smiling. She must be happy that she has a child. She must be taking care of the child. What if she has a lack of sleep? She has to feed the child, get her to sleep, and play when they are awake. But there is exhaustion. There is exhaustion from the delivery, from the 9 months she was away from her normal daily routine. So there are chances of being mistreated by the family increases when she starts behaving, when she starts looking sad, when she is not able to take care of the child. The family members, they don't understand. They just mistreat the mother. So, what symptoms a woman might experience? All the depressive symptoms might happen. It is basically more serious than what we call it as a baby blue. So, that is not baby blues. They might get suicidal ideation. We have got cases wherein the mother has killed the child also and has committed suicide also. So it is an emergency, and we need to treat the woman immediately. There is something called as postpartum psychosis also, wherein it's a kind of psychiatric emergency. And yes, we need to treat the patient. And in postpartum psychosis, the woman might have symptoms such as hallucinations. She might have symptoms such as delusion, a feeling that someone might harm her, a feeling that the child is there to harm her, or it is better that she kills the child because it's a bad luck to her. So all these thoughts might come to her brain, and many more so, which leads to postpartum psychosis, and we need to treat it immediately. So the next is very commonly we seen in young women, premenstrual syndrome. As we know, the menstrual cycle comes every month, and for some women it is not very easy going because they experience a lot of changes. Apart from the physical symptoms, there are emotional changes that they suffer from, and that is not good for them. Some of them may suffer from both physical and emotional symptoms. They may experience tenderness in the breast, they may experience mood swings, there is fatigue, there is food craving, irritability, and depressive features like low mood, lethargic, lack of interest in pleasurable activities, crying spells. Some of them may have excessive irritability during that period. Some of them may get aggressive during that period, agitated during that period. So we have to help them out during that period also. So that is premenstrual syndrome. So these were the common mental health disorders. And what about severe mental health disorders? Severe mental health disorders basically include disorders like schizophrenia and bipolar mood disorder. So for them, there is no, frankly speaking, there is no marked gender differences between men and a woman. And it differ. However, the difference that is seen is in the age of onset, the clinical features, the frequency, symptoms, and course, and the prognosis, of course, for some disorders. So, but what the difference? Another difference that we see is the consequences like abandonment from the marital families. We have got patients wherein the family starts blaming the female that you have been suffering from this from before marriage and you didn't tell us and everything. And there is a lot of trauma to the female that is given. There is homelessness, there is vulnerability. They become more vulnerable to sexual abuse. So these are the differences that we see in severe mental disorders for women who are suffering from schizophrenia and bipolar mental mood disorder. So suicide. What the pattern that we see in females is that worldwide, female attempters of suicide is more, and males, they have got higher numbers, they are in higher numbers to complete the suicide. But India has slightly different statistics wherein the women outnumber the men in completed suicide. As per the Indian government statistics, what are the precipitants of suicide in India? First is the psychiatric disorder. It could be anything: depression, extreme anxiety, schizophrenia with suicidal ideations, with command hallucinations, bipolar mood disorder, and there are other social factors which include dowry disputes, love affairs, illegitimate pregnancies, and quarrels with the spouse. Yes. So, yes, the survivors, women as survivors of gender-based violence, it is also another socio-cultural factors that affects our society. So women in our society, they are conditioned to blame themselves for broken relationships and abuse. They might experience the shame. They may have a belief that they are violated. They may have a belief that they are now used goods. They are worthless and nobody will marry them in the future after an abuse or domestic violence, that they have somehow destroyed the family honor. In fact, going to with the statistics, 10 cases of cruelty by husband and relatives are reported across the country every hour. So the next concept that I would like to explain here is learned helplessness. So we must have seen as health professionals, as women who are into an abusive relationship, wherein there is history of domestic violence happening constantly. The husband may or may not be alcoholic or into any substance. But even if they have a chance to get out of the marriage, and even if the maternal side of the family is supportive enough and they want to take the daughter back and they want the daughter to come out of the abusive relationship, there is chance for them to walk out of the relationship. But somehow she don't do that. Most of them maybe don't do that. What do we think of the female in such cases? What comes to our mind? Why didn't she leave? Why? So maybe she liked it, or she is used to it, or is she lazy? So, well, as mental health professionals, when we talk to these women, what answers do we get commonly? Some might tell that, my children need their father. Some might tell you that I can't leave him. He can't survive without me. Or where will I go? Or I am helpless and there is no way out. Or some might tell you that, divorce will bring disgrace to my parents. So all these reasons they give. But is it valid enough? Or is it fair for them to stay in the relationship with all these reasons? So, what is learned helplessness? Basically, this concept it's a psychological phenomena where any person, any gender, whether it's a male or a female, if they are constantly if they are constantly exposed to repeated trauma in a relationship or anywhere else, what happens is that they start accepting the condition. They start feeling that they no more have the control over the situation. Yeah. So that is learned helplessness, wherein they feel that they have lost control over everything and they have to stay over there helpless. So yes, in lot of domestic violence cases and abusive relationship cases, and women coming to us with depression and anxiety, we do see this phenomena of learned helplessness. So yes, uh, after telling you about all this. So, how do we help our women? We know that a woman coming to us with depression, with anxiety features, we know what to give. We know with that we can help them with the antidepressant pill, anti-anxiety pill, and but is that enough? Or for schizophrenia, say we have to give them antipsychotic. There are mood stabilizers, but is that enough? That helps. Yes, that helps with the symptoms and everything. But what about the social and the cultural factors that affect these women's mental health? Will they be treated completely? So, what do we have to do? We have to educate them. We have to make them realize about their rights, about the patriarchy system and the model of the society, about abuse and how it works. We have to teach them certain coping skills. They have to undergo therapy, and we have to teach them how to recognize certain signs of abuse. There should be an understanding of POXO acts and domestic violence acts. For this is for both men and women. And yes, coming to my last slide, listening to all this, maybe every one of us might be thinking, oh, Dr. Rashmi is a feminist. But yes, I would like to say that feminist is a bit misunderstood term. Basically, what feminist means, we have to understand that one has a belief, a person who is a feminist, they have a belief in equal opportunity and equal rights of both genders. And not only women, even men can be feminist, and they should be a feminist. Giving, because as we know that the theme of the mental health um, day of this year is mental health is a universal human right. So it should be there for women as well. So yes, I would like to thank you and end my session on a note that next time a woman walks into our OPD, we should be thinking beyond an antidepressant and an anti-anxiety, because that's when we can help our women. We have to make them realize how the social and the cultural factors affect our women mental health. Thank you very much.
Thank you, Dr. Rashmi ma'am, for enlightening us with the importance of mental health in women in a very beautiful and a concise way, and summarizing briefly how different aspects of life and society affect men and women's mental health differently. Thank you, ma'am, once again. With this, I would like to call upon our next speaker, Dr. Pratik Surandashi, to put some light on geriatric psychiatry. Dr. Pratik, he is consultant psychiatrist, co-founder of Man Arogya Psychiatric Clinic, Borivali, Mumbai. He has done his MBBS from KEM Hospital and MD in psychiatry from Nair Hospital. He is having 10 years of experience. He
Correct.
has special interest in geriatric psychiatry and also treats children, adolescent couples and sexual health problems. He is
ठीक है.
trained in cognitive behavior therapy. Dr. Pratik Surandeshe, over to you, sir.
Dots को mute के बाजू में dots हैं.
So, thank you so much. And the true measure of a society is how it handles and how it treats its most vulnerable. I believe that in a nation, women, children, and the elderly, these populations are the vulnerable ones. So my presentation today, I'll just share the screen. Okay, Dr. Manoj, you got to make me the host so that I can share the screen.
Yes, sir. You.
Yeah.
Sir, you can share.
So my topic today is dementia, signs and early interventions. At the outset, I would have to say that excellent presentations from Dr. Mansi and Dr. Kashmi. My presentation will cover the signs and symptoms of dementia so that it becomes a very easy thing to pick up any cognitive issue early on, and at the same time any interventions which we can do to kind of help the person with dementia, at the same time the caregiver. Now when we speak of dementia, it's a disease. Actually, it's a disease process, gradually progressive, and it causes cognitive impairment. It is a it's a ailment which affects daily routine activities, and the prevalence varies from around 5% in 65 to 70 years to more than 20% above the age of 80. The population affected due to dementia will approximately be around 82 million by 2040, which might include most of our speakers and the audience today. I hope not, but might just. Yeah, when I speak about cognitive impairment, there are certain domains of cognition. So cognition is our thought process. So there are some domains which are impaired, and these impairments are seen in dementia. So the domain which are impaired are memory and learning, language, orientation, social cognition, perceptual-motor difficulties, attention, executive functioning like planning, organizing, sequencing, and abstraction. So the signs and symptoms as per the domain which is affected. So if the domain affected is memory, now not every dementia has memory loss as the only symptom, but at the same time, it's one of the most commonest symptom of dementia. And the most common type of dementia that we see is Alzheimer's type. Though Alzheimer's dementia is a diagnosis after the death of the person, it's a pathological, or it's after we obtain a biopsy. But yeah, coming back. So the domain affected, if it is memory, the recent memory is something which is affected first. So the person with dementia might not register what is happening in the present moment, or maybe as in the recent past as a day prior. So they might not remember if they've had their meals. They might not remember who they were meeting. This was a little bit of a problem during the COVID pandemic, where the senior citizens didn't understand whether they have to wear masks, why are they wearing the masks, why do they have to maintain a distance. So yeah, recent memory is impaired the first. The signs and symptoms in that. So the person with dementia, might just forget names, and even names of people, their family members. They might forget faces, their dates, appointments, they can't keep track of conversations. So the kind of speech that they have, the conversation with a person with dementia is very repetitive, because they can't register what they are trying to say. They lose track, and they start again. They might forget objects. So commonly they misplace their own belongings, and it causes a lot of trouble to everyone. Um, Again, the long-term memory is affected in later stages, in advanced stages of dementia. So the person might not ever forget where he was born, where his schooling was, where did he go, and where did he start working earlier, and so on and so forth. Um, but there is a caveat. I would say any memory loss which is disrupting daily routine activity must be assessed. And it is very important to differentiate dementia from pseudodementia. Pseudodementia is the other name for depression. Now, there are times where people with low mood might just complain of memory issues. But there is a very simple way of differentiating dementia from pseudodementia. So, in a person with dementia, they would say they would never be able to register, and they would never be able to report when their memory loss started, as opposed to a person with pseudo dementia or depression. They would say 3 महीने से चीजें भूल रही हूं मैं, या 3 महीने से चीजें भूल रहा हूं. On objective assessments, a person with dementia will always give approximate or wrong answers, whereas a person with depression or pseudo dementia would say, I don't know. A person with dementia is more interested in hiding their cognitive impairments, as opposed to depression, where they are coloring and giving a very detailed account of their memory problems. So yeah, if the domain affected is memory, these are all the signs and symptoms that we can see. Now, if the domain affected is language, it is very commonly seen that a person with dementia might just have difficulty finding the correct word, or even naming is an issue. The speech is very impoverished. So वो phone call आपने लगा के दिया है, it's a video call, and the person on the screen is asking, how are you doing? And the person with dementia is, okay, I'm all right, not a problem. And they don't say anything beyond that, because again, language is impaired. They have difficulty initiating conversations. So you might see these people sitting uh, in a group of family members or friends, but not being able to speak at all, and this causes a lot of distress to the person with dementia. Now the next domain affected is executive functioning. So it is this part of our brain which is called the prefrontal cortex, which actually is a seat of executive functioning. So when we see a senior citizen with impaired executive functioning, they can't multitask. So it's very difficult for them to maintain finances, to manage going from one place to the other, or to drive a car, or even to maintain medicine schedule. Now, senior citizens are very commonly on many types of medications. So they can be antihypertensive, they can be medicines for diabetes, asthma, arthritis, and it's very difficult for a person with dementia to maintain a medicine schedule. They can be very impulsive, and their judgment is impaired. So they can let strangers into the house, or they can be lured into making bad financial decisions by people who might just exploit the fact that their judgment is impaired. Now, if it is the attention and orientation which is impaired, the person with dementia is very highly distractible, not be able to focus at one point for a very significant amount of time. They might appear confused, and sometimes it has been seen that a person with dementia would say, I would want to go away from here. This is not my home. I don't know where I am, but my home is somewhere else. And they would want to leave the home or wander away. Social cognition. Now, this is a domain which, when affected, causes a very high caregiver burden. And the person with dementia, most often than not, whenever there is an old age home placement, it is this domain which is the most severely affected. So the problem with dementia is they have an inability to understand expressions and emotions of others. the caregiver might just cry or be angry at them, but the brain is such, the condition of the brain is such that it might not be able to even understand what the expressions on the face of the caregiver is or what the emotions that they are experiencing. There might be change of worsening of personality. Now, when it's about worsening of personality, specifically in the Indian scenario, the family members would be like, "Papa तो पहले से ही गुस्सा करते थे, अब worst हो गए हैं थोड़े." He's not having dementia. He's just gotten much meaner. Is what they would say, but actually, it's a problem with the social cognition domain. Now, there might be senior citizens who might pass sexually or politically inappropriate statements, and these are between people who are very sensitive to these kind of statements, and they might get into trouble because of this. There are disinhibited behaviors. Now, sometimes it just so happens that when a senior citizen, now this we have seen with even the female gender patients with dementia, that they have touched the female attendant inappropriately, or both of them, male and female gender both, or have been very disinhibited, so they might have disrobed when they are in the family members in the home. Now, when the domain affected is perceptio-motor, meaning the person is seeing something, but they can't use their abilities of skills. They can't use their skills to navigate through life. So they have difficulty doing tasks which they have learned earlier, like driving or using gadgets like remote or the smartphones. When it gets worse, when the dementia is progressing and it's in the severe stage, the activities of daily living like bathing, feeding, clothing, toileting, the person with dementia becomes dependent on the caregiver for all these activities of daily living. Also, the problem when this domain is affected is that the person will not be able to understand that their behavior is causing some problem. Sometimes it gets so worse that the person with dementia can't even recognize themselves in the mirror. Now, the next topic is neuropsychiatric symptoms. Pardon me that. So yeah, for neuropsychiatric symptoms, the commonest, and when I say neuropsychiatric, it has, because the illness is in the brain tissue, at the same time it has behavioral repercussions. So these are the symptoms which are actually the most distressing for any caregiver, at the same time the person with dementia. So the commonest emotional issue or the neuropsychiatric symptom is anxiety, and I've written there catastrophic reaction. So there are times where some caregivers try to push the person with dementia to answer something, and that is a point where they realize that, oh, there is a cognitive impairment in me. But to acknowledge that means, it is a very impactful event in that person's life to understand that their brain is failing, and that can cause a lot of anxiety, that can cause a lot of agitation. Then the other symptom is there are symptoms of psychosis. Now, psychosis is a loosely termed for loss of touch with reality. People with dementia might just have hallucinations which might both be auditory or visual. When it's about visual hallucinations, very commonly seen in person with Parkinson's dementia. But in visual hallucinations, they might have very vivid hallucination. They might see people in the room. Room ke andar koi baitha hua hai. The caregiver is saying there isn't anyone here, but they're saying no, there is a person. There is a crowd of people. There are insects in the room. There are patterns in front of me on the wall which I can see. Now, more often than not, the visual hallucinations are during the night time, because in the daytime there is light everywhere, so the brain can see that, yeah, there isn't any person here, it's in the dark. So we would always advise the caregivers to put on at least a moderately bright light in the same room. The other thing with regards to psychosis, and this is one of the very classical symptoms of dementia, is delusions of theft. Now, the person with dementia would keep their play, will not remember where they kept their belonging, and because of the memory impairment, they would blame it on the caregiver, and the caregiver, is the primary caregiver. Whoever is in the family will have to bear the brunt of something like this. There are times where persons with dementia would take their, whatever precious belongings, and they would store it somewhere, and then they would forget that where they have stored it. So again, they would blame the caregivers for that. Another one is depression. Untreated depression will progress into dementia. So very necessary to have our senior citizens go for neuropsychological testing for just picking up depression. And depression, again, the other name was pseudodementia. So when a person realizes their dependence on their caregivers is increasing, and the activities of daily living are getting affected, uh, there is a sense of loss, and they experience it as low mood. Sleep disorders, commonly in our senior citizens, their sleep schedule is reset, so they might sleep early and they might wake up early. So also they might complain of poor quality of sleep. There are so many senior citizens and people in every family who might be buying sedatives without prescriptions, and they have been on such medications for a long time. Agitation. Now, agitation is a symptom, and it can manifest in various ways. The person can be pacing in the room. They could be rocking back and forth. They might just go through their drawers trying to find God knows what, but they rummage through the drawers. They might be picking their skin or even scratching themselves. There can be aggression, which can be physical, where they might hit someone, they might throw any objects to break them. There might be verbal aggression again. If social cognition is affected, then the language is also very rude, and it is very troublesome for the caregiver to understand that, okay, this person doesn't remember these things, but they can understand what this word, this defamatory word means. Aggression is again sexual aggression and can be exhibited by both male and female persons with dementia. So those were the signs and symptoms of dementia. Now we can move on to early interventions. So the first thing, if ever a person has been, family member suspect, or a person suspects that there is some memory issue, what is advisable is to go for psychological assessment or neurological assessment. One of the rules to make it easier. So if it is about emotions and behavior, psychiatrist would be the person to go to. But if these are with regards to movements, if these are with regards to weaknesses or stroke-like symptoms, then the first person to be contacted is the neurologist. Now, in a neuropsychological evaluation, what we try and do is to see what is the severity of the dementia process, what all domains are affected, and at what stage that person is. So the basing of therapy for that person also depends on these evaluations. And basically it also tells us somehow about what kind of dementia are we talking about. So something like Alzheimer's dementia would have a very slow onset and a very gradual progression. As opposed to that, vascular dementia has a very acute onset. The symptoms start just abruptly, and there is a step ladder kind of a pattern to the decline in cognition. So that's neuropsychological evaluation. There are some blood investigations and imaging that we have the person do, and again, it's a good sense to get the blood investigation just to also find out if there are any other medical comorbidities like hypothyroidism, diabetes, if there is any issue like hyponatremia. Again, a lot of our senior citizens have confusion, disorientations, and blood investigations and imaging. Sometimes even a CT scan would do for a person with dementia. And what we see as clinicians is that there is a flattening of the gyri and the deepening of the sulci, and we see that there is a shrinkage of the brain parenchyma with the ventricular volume increasing. So pathognomic signs we can pick up on the imaging studies as well. Um, The crux of doing such investigation is to identify treatable causes of dementia. Normal pressure hydrocephalus, hypocalcemia, hypoglycemia, hypothyroidism. These are certain subdural hematoma. These are certain ailments and HIV induced dementia. These are treatable causes of dementia, and picking them up would really help us to at least stop the disease process, or to even regain back some of the function, because it's not the depletion of the nerve cells, it's actually some disease process which is causing some problem. The next intervention is to optimize the living area of the person with dementia. Now, it's very necessary to have uniformity, or what I would call very vaguely is sameness, meaning the room of the person with dementia has to be a very uncluttered room, not much furniture there. There can be things which are very accessible to them. The bed can be very low so that getting up or lying down becomes a bit easier. There is no kind of risk of falling. Another thing, there can be memorabilia which are kept near the bed of the person, so that they can reminisce. Somebody sitting with them can reminisce that, oh, do you remember where we had gone for this when we had taken this photo? So it leads to a little bit of rejuvenation of the memories at least. And another thing which people with dementia would have a lot of problems with is if at all it's an advanced stage, then walking would be a really big problem. So having the person use a walker or using a wheelchair, having handles, metal handles installed near the commodes, very necessary to help the senior citizens get up easily, and this is to even prevent the chance of a fall. So optimizing the living area of a person with dementia, very necessary. Starting medications, to this date, we don't have any medication which reverses the disease process or helps us to regenerate the neurons that we've lost. So starting medications and the rationale behind starting the medication changes with the stages of dementia. When these are the earlier stages, meaning not many domains have been affected, we treat the person to preserve cognition. So the medications which are available, mainly the acetylcholinesterase inhibitors like donepezil, rivastigmine, galantamine, in patches or in oral formulations, and the NMDA receptor antagonists like memantine. So starting these medications are with the rationale behind them is to just to a certain extent reduce the deterioration or slow down the degeneration in the brain, so that the person can be helped with a bit easily, and otherwise the cognition would just deteriorate like this straight up. It goes down. But if we give the medicines, then there's a curve to that, and helping that person becomes a bit easier. So starting medications, again, this is a step which many caregivers take a long time to start, because they feel that, okay, this is not dementia. So it is necessary to even understand what dementia is. So it is highly advisable for caregivers to attend support groups, to know everything about dementia and about how to care. Last but not the least, formulating a will. Uh, the legal matters to be handled before the cognitive impairment becomes very severe, so that there aren't any disputes afterward. I would also ask patients to maybe even formulate advanced directives, meaning during the advanced stages of dementia, would they not want to be resuscitated, or would they have an advanced directive of withholding treatment? So these are certain things that we have to respect, as it is the will of that person. The dementia is a process which is like we have heart failure or liver failure. Dementia can be called brain failure, and it is progressive. So once it has started, the disease might take maybe a couple of years, 3 years, more than that if treatment has been started early. But eventually we end up losing the person. So the life of a caregiver of dementia is difficult, very helpful to engage a lot of family members, to use official caretakers from some agencies to help yourself care for the person with dementia. Now, this is one slide which I have incorporated, and this is my last slide actually. There are a lot of questions I'm asked most often than not about how to prevent dementia. Is there something that a person can do to preserve cognition? Now, this is what we call as a Mediterranean diet, but basically it is a diet rich in whole grains, millets. It has vegetables like broccoli, cauliflower, fresh fruits, mainly fruits which are very rich in vitamin C, which are like citrus fruits or amla. But decrease in red meat is highly advisable for good brain function. Controlling diabetes, controlling blood cholesterol and blood pressure, very necessary. If at all these disease processes are uncontrolled, then there is also very early onset cognitive impairment that we've seen. Quitting alcohol and tobacco also very important, because again alcohol and tobacco would affect the vasculature of the brain, and which again would cause neurodegeneration. Socialization. Now, socialization can be for spiritual activities, religious activities, as valued, that the person might value socialization. So very necessary for that person to socialize with their friends and maintain that activity till it permits, health permits. Yeah. Learning new skills. So sometimes people would just say that I don't want to learn a new instrument, or learning a new language would be difficult. What I would say to them is, then just try writing with your left hand. If you're a right-handed person, write with your left hand, or even use a spoon. Use a left hand to comb. See how you feel after that. And even that has been shown to fire up some neurons which were at least quiet. Then the next one is yoga and exercise. This is a very ancient Indian way of life, and going for Anulom Vilom Pranayam, Surya Namaskar, very necessary. Exercise and daily 30 minutes at least of exercise has been shown consistently to halt the neurodegeneration, to halt the decline, the cognitive decline, and started from a very young age, pays rich dividends. Sometimes having our senior citizens have supplementations of vitamin D, folic acid, vitamin B12, very helpful in dementia prevention at least. There are certain therapies which have no significant research, proving their effectiveness. What few of those I have mentioned here: stem cell therapy, piracetam, acetyl L-carnitine, coenzyme Q10, ginkgo biloba, vitamin E, citicoline, omega-3 fatty acids, coconut oil. So there might be a lot of WhatsApp forwards which might come, and suddenly there is a cure all, there is like, oh, this is the wonder drug which has come out into the market. Necessary to speak with the dementia specialist once in a while, just to care for your patient properly. So thank you everyone for your patient listening. If at all there is any caregiver who is in the group, or there are patients with dementia, anybody has been treating, these are certain websites where they can find some kind of help, or at least informations about support groups. Thank you so much for your patient listening.
Thank you so much, Dr. Pratik. It was an amazing lecture. Hello?
Yeah. So
Sir,
thank you so much.
yeah, thank you, Dr. Pratik. It was a very nice lecture, and I would like Dr. Sakib Dani sir to please continue after this. We don't have any questions in the chat box though, but we keep the forum open so that if any one of you wants to ask any question directly to either Dr. Mansi, Dr. Rashmi, or Dr. Pratik, can go ahead and ask questions. Unmute yourself and please ask questions if you have any.
First question I want to ask to all the three panelists: how should family physician or any doctor take care of their own mental health? I want their decision. I want their this thing views. Yes, Mansi.
Sir, I think the most important thing is to understand that work is only work, and beyond that, we all have a life. Family plays a very big role. So, after finishing, many times we get so caught up and we are always prioritizing patients. मतलब हम हमेशा patients के या तो पीछे भाग रहे हैं या उनके लिए कुछ ना कुछ कर रहे हैं, but हम भूल जाते हैं अपने लिए. हम excuses देते हैं कि टाइम नहीं है, मुझे ओपीडी जल्दी चालू करना है तो एक्सरसाइज के लिए टाइम नहीं है, या फैमिली के साथ नहीं जा सकते क्योंकि इमरजेंसी आ गया है. सो थोड़ा सा प्रायोरिटाइज करना अपनी चीजों को, समझना कि काम जरूरी है, लेकिन अगर हम अपनी हेल्थ का ख्याल रखेंगे तो ज्यादा और काम दे पाएंगे. सो प्रायोरिटाइजिंग फैमिली, स्पेंडिंग टाइम विथ फैमिली, जो चीजें हमको हैप्पीनेस और एनर्जी देती है, जैसे हमारी हॉबीज है या स्पिरिचुअल है, रिलीजन है, उन चीजों को फॉलो करना. दीज आर द थिंग्स आई पर्सनली बिलीव के हम डॉक्टर्स कर सकते हैं जिससे हमारी मेंटल हेल्थ बेटर हो.
डॉक्टर रश्मि.
जी सर, बहुत पॉइंट्स तो बहुत सारे हैं सर. मतलब आई थिंक इस पे एक लेक्चर हम ले सकते हैं, लेकिन जो मैंने बहुत कॉमनली सर देखा है, मैं एक ही पॉइंट फिलहाल बोलना चाहूंगी, वो है नींद. मैंने बहुत जनरल फिजिशियंस को मैं देखती हूँ, आई थिंक दे आर द बिजिएस्ट. वो उनकी किसी किसी की ओपीडी 12 बजे 2 बजे भी खत्म होती है, एंड दे स्लीप लाइक आई डोंट नो वो कैसे सर्वाइव करते हैं. आई डोंट नो दैट, बिकॉज दे समटाइम्स दे टेल मी दैट हम 3 बज जाते हैं सोते सोते, दिन सुबह फिर ओपीडी चालू करनी होती है. तो वी ऑल नो कि नींद कितनी इंपॉर्टेंट है हमारे मेंटल हेल्थ के लिए. एक चीज एक टाइम पे भी हम करेंगे तो भी बहुत है कि आप स्लीप को थोड़ा सा ध्यान दे करके नींद एक आप 5 से 6 घंटे की आप लें, तो आई थिंक वो ही एक फर्स्ट स्टेप होगा और बहुत बड़ा इम्प्रूवमेंट होगा. थैंक यू सर.
Dr. Pratik, your views?
Yes, sir. I'll keep it very concise, and this is something which even I am struggling with. But good and balanced nutrition, exercise, and lot of sleep. So this is something which will help all the medical practitioners again, because our time is valuable for someone's life, and when we are invested in our patients, we forget that we are also mere mortals. Physician, take care of thyself.
Very good. I want to summarize that we should understand that we are also human beings. We are not magicians, we are clinicians. We have to take care of our health first and take a break before it breaks you. And enjoy your family life also, spiritual life also, social life also. As we are doing in Miraband, a lot of activities, lot of this thing. But we should not neglect ourselves. पेशेंट को दूसरा डॉक्टर मिल जाएगा, हमारी फैमिली को हम दूसरे नहीं मिल पाएंगे. That is the most important concern. Any other question?
Sir,
Yes, sir.
I have listened all the lectures. It was excellent.
Thank you, sir.
Especially pediatric and female also was excellent. One's health, and sir also covered the old age problems. What I came to know that the adult psychiatry and the male psychiatry is completely not taken care by all of you, the genius one. Many people I have seen the impotency, depressions, loss of element from the business loss, or behavioral problem in the family, which creates lots of problems because of lifestyle, corporate jobs, all these things creating the problems in the family as well as in behavioral troubles and addictions. All these things are really troubling nowadays because of lifestyles. So I have requested in the chat box that such a types of lectures should be arranged, because ma'am has covered an excellent touchy lecture for the women and even children. So we need a recording of all these things so that we can forward to the best people. And
Next
we'll
time,
definitely aware these mental health excellent programs done by our team, and we need a recording. That is sure, ma'am.
thank
It's
you, sir.
live,
Uh,
live session.
No, but in future, if you want to spread, such a program was conducted in Mirabai, we can spread the recording of these lecturers, and it will help both the way to the lecturers as well as then to our patient also and to the doctors also.
So it's a live session.
Huh?
You can go to YouTube, Bhindra Medical Association page, and watch.
Okay. Okay. That's
YouTube पे live है, ठीक है, okay, okay.
well done all. Well done all.
Thank you, sir. Thank you. And next time we will keep on such lectures regarding topics which you will decide. We will keep on arranging.
Okay, sir. Okay. Thank you.
Any other
Please,
question?
Pratik sir, please make me host.
Yes, sir. I've done that. You are the host now.
Thank you.
Any
Hello?
other questions?
Hello.
Yes.
So there is one question for Dr. Pratik. When he was talking about dementia, he said it is for senior citizens. Does it happen in young age?
So dementia, like I said, is a disease process. Now, if there are any vascular ailments, now if there are any stroke, and these days I think heart and brain both are taking a beating for even the late 30s or early 40s. And if ever we see a person with a vascular injury, what happens after that with the neurodegeneration and everything? If the major blood vessel is involved, we see a lot of dementia processes happening very prematurely at a very young age. We have seen at as young as the late 40s or early 50s. Classically, dementia would start by, because of aging. We would say maybe more than 65 years of age, it would be very common to see dementia. But in something like a vascular pathology, early onset dementias are very common.
Last question to Dr. Rashmi, ma'am. Ma'am, we have elaborated very nice the mental health of the woman. Also, you
Thank you, sir.
suggested some educational therapy to the women. How you are conducting the educational therapy to the women who are failing for the pharmacological agent, or along with the pharmacological agent, how you conduct the same educations to the women? What is the different way or any centers?
So basically, when you ask me, what I do is I practice both pharmacology and psychotherapy. When a patient, so far I'm not conducting any group sessions or any psychoeducation session for a collective group of women. But yes, of course, in future, if I get the opportunity, I will take up for it. But for patients, for individual patients who are coming to me in my OPD, I definitely look beyond the depression, because just giving the patient an antidepressant for like 6 to 8 months and they are treated, that doesn't mean that the female will never come to you with the same symptom again. So we have to look at the psychosocial factors also, about what is she facing at home and what is the actual problem. We need to teach them the coping mechanisms and to stand for them, being assertive and other techniques, so that in future they don't face the same problem. Thank you, sir.
Nice.
Any other questions? I think we are on time. So, Manoj, wind up कर दे.
Yes, sir. You can.